Okay, actually taking it a step further, we don't know the right answer, and the patient decides to forego transplant. In this particular scenario, what's your maintenance therapy going to look like? For how long? Is it dual? Are you going to drop a few things? What is that conversation like?
So again, I think what we'll do at that point is go back to the original risk of the patient to understand what the relative intensity of the therapy needs to be to maintain the success that you've had that far. So if you have a standard risk patient who was treated with DARA or Len, Velcade, Dex, for example, they get to MRD negativity, they decide they do not want to go to transplant anymore. I think that's a discussion where you can de-escalate and you could think about what is probably driving the most toxicity with that regimen is your bortezomib, right? So you could probably think about getting some amount of cycles done, and maybe we choose 8 cycles to kind of get the bortezomib in there with the four kind of eight, excuse me, 8 total cycles of therapy. Drop the bortezomib at that point. Certainly get rid of the dexamethasone, and think about should I continue on single or doublet at that point. For your average standard risk patient, you probably could get away with just lenalidomide moving forward. For your average high risk patient who decides to forego transplant, much to the chagrin of your transplant doctor, even at MRD negativity, we think that you're going to need continued intense therapy. That probably looks like triplet therapy in my mind. That includes probably the CD38 monoclonal, the proteasome inhibitor, and the IMID. No Dex. I think Dex is what really does the most trouble or adds the most toxicity to our patients and probably does the least in terms of myeloma killing. So for my high risk patient who foregoes transplant, I'm going to want to continue as much of the drug as I can. So if it's 3 drugs, that's where I think about, okay, we want to do 3 drugs. What is the frequency and can we do any dose de-escalations? And no one knows what to do here. If you ask different centers, you're going to get different answers. There are certainly centers out there who continue on with carfilzomib, for example, at twice weekly and carry on 3 weeks in a row, 1 week off. I'm not sure we need to do that for everyone indefinitely. Um, you could follow some of the Forte data that tells us that you need to do, carfilzomib and lenalidomide and do that for a couple of years and then drop the proteasome inhibitor. So I think the short answer to the long question is continue on intensive therapy for our high risk patients, doing the best we can to make it tolerable and durable.
Sticking with the maintenance theme here, so now the patient has undergone, of course, transplant, whether it's a standard risk or high risk. In terms of maintenance therapy, how are you deciding which one to go for, whether it's a standard risk or high risk there?
A lot of the maintenance decision is made based off of the induction regimen and based on the risk of the patient. So, in your average standard
Okay.
risk patient who underwent quadruplet therapy with DARA RVD, had a transplant, remember the Griffin and the Perseus studies both continued DARA and LEN together for a handful of years before dropping the DARA and continuing on LEN. Now, they also did consolidation, which I would argue many of us don't do either. So, the further away we get from the original trial design, in theory, the further away we could get from away from those same successes. So I think it's worth the conversation with these patients to say, this is how it was done, and this is what I propose. I think with your standard risk patients, you could get away with LEN maintenance as it was originally done and designed, and maintain CD38 sensitivity, perhaps for first relapse. So you can retreat
Mhm.
patients with DARA as an example again. For patients with higher risk disease who, for example, may have had DARA KRD as their initial induction, these are patients at post transplant. I really like, kind of per the Forte trial, to continue them on with both a proteasome inhibitor and the IMID. There is the best data for proteasome inhibitors and maintenance for our high risk patients than there is with monoclonal antibodies, for example. I think there's meta analyses that are out there that tell us that DARA probably is good enough to overcome some of the high risk features in these patients that you could continue it with the maintenance setting, but the proteasome inhibitor IMID combination is probably a good backbone to continue patients post transplant for maintenance with high risk disease.